What other treatment options are available for patients with relapsed MM? So, what about this CAR-T? Today, we introduce this new therapy. What is its principle? Well, it's essentially like a targeted bomb. We know that our tumor cells actually look different from normal cells. If our immune system is relatively normal, we can recognize some early tumor cells. Our T cells, our lymphocytes can identify them. They recognize them as abnormal cells, and they can eliminate these abnormal cells. But when our immune system is weak or when tumor cells form a mass, we struggle to resist these tumor cells. So, what is the principle of CAR-T? It's about taking our own T cells, our guardians of health, and modifying them to give them the ability to recognize tumors. It's like giving them a spotlight. It's about putting this BCMA, we call it B-cell maturation antigen. This is a marker on the surface of myeloma cells, a marker. A molecule, we install it on these T cells. So they can recognize through this marker, through this guided direction, and then identify the tumor, and then come to the vicinity of the tumor, and destroy it. One is BCMA, this marker, which will be installed inside these modified T cells. Second, it also has the ability to self-amplify. Because relying on our natural amplification, it has its own cell and growth pattern. But if we modify these CAR-T cells, they can self-replicate. That is, they have this self-replication capability. How effective is the new drug treatment for the first relapse of multiple myeloma? So, about these adverse reactions. There are actually quite a few, though many are listed. Overall, we feel these adverse reactions are manageable because most of our patients are treated on an outpatient basis, which means the overall toxicity isn't that significant. It's also relatively mild. Many patients don't feel very uncomfortable, lose their hair, or get high fevers. Actually, these are not very common, so please rest assured about this. The current treatments are quite effective and also very safe. Something to pay special attention to is various medications, which may have some neurotoxicity, especially drugs like bortezomib. Lenalidomide and pomalidomide also have it, including thalidomide and ixazomib. They all have some neurotoxicity, so neurotoxicity is common among these types of drugs. There are also some gastrointestinal reactions, like some people might have diarrhea, constipation, or vomiting. About ixazomib, its gastrointestinal reactions might be more apparent, but if we strictly follow its instructions for use, such as taking it on an empty stomach, once a week, and adjusting the dosage, if we manage these well, it can fully bring out the drug's better effects. Then there's also some like carfilzomib and pomalidomide which may cause a decrease in platelets and white blood cells. Just now, talking about carfilzomib, its cardiac, may also have some specific toxicity. Also, there's thrombosis. Like immunomodulators, like lenalidomide, pomalidomide, they may increase the risk of thrombosis, and so on. Of course, steroids are also something people are more concerned about. We have an old patient who has been a patient for 10 years and is still doing very well. He can still take care of children normally, travel around, and so on. His recent relapse, we treated him with carfilzomib and steroids. But he is very concerned about the side effects of steroids, because after a long time, indeed, with long-term use, the side effects of steroids should be watched out for by everyone, including immune suppression, osteoporosis, weight gain, and so on. There may be some of these side effects. What treatment options are available for first-time relapsed MM? In this first-line treatment, we call it first-line treatment. After contracting this disease, our preferred plan is bortezomib, lenalidomide. These two drugs are still a preferred combination. After relapse, immunotherapy, such as monoclonal antibody CD38, has been approved for initial treatment patients. Its efficacy during relapse is also very certain. Many guidelines categorize monoclonal antibody drugs as the first choice after initial relapse, because, although approved for frontline treatment, our country, China, hasn't reported it. So, patients in relapse can be reimbursed. What else? Bortezomib or lenalidomide for its subsequent, including carfilzomib, ixazomib, as we just mentioned, pomalidomide, etc. And there are some others, which are different mechanism drugs, including inhibitors of active output proteins, which is an orally administered small molecule inhibitor, selinexor. How effective is the new drug treatment for the first recurrence of MM? So, in this regimen with these drug combinations, we can see this efficacy progression-free survival, as well as overall survival. These three are all from several clinical studies, such as CD38 monoclonal antibody, combined with lenalidomide and dexamethasone. This is the DRD, compared to RD, which is lenalidomide, combined with dexamethasone. The results of 3 drugs versus 2 drugs currently show that at the time of first recurrence, the efficacy is very good. But as you can see, it takes over 50 months to recur for the first time. Isn't that good? It's over 4 years before recurrence. But it should be noted that at that time of the study, many patients had not previously used lenalidomide. So now, most of our patients have used lenalidomide in the first line. So at recurrence, using CD38 in combination, such as possibly in combination with pomalidomide data, may be more applicable to our current status. Because when this study released its data, it had been studied for several years. So the regimen used in the study design may be different from our current situation. But anyway, from this recommended study regimen, we can also see including CD38 monoclonal antibody, including carfilzomib, including ixazomib, pomalidomide, carfilzomib, etc. These drugs are still widely used in our relapse. Relapsed/refractory multiple myeloma. What are the treatment goals for RRMM? So what are its treatment goals? And if we ourselves are patients or family members, we actually have a particularly deep understanding, we hope. Doctor, you don't tell me that this disease is incurable, etc. Because these words are actually something our fellow patients don't really want to hear. Actually, here I think a lot of what we're presenting today might be from our academic perspective, because this disease in the past 20 years has made significant progress, so what we're discussing now is like this in another 2 or 3 years, or 5 years there might be significant breakthroughs. So although we're discussing this disease, but more importantly, we still need to talk about our current state. Whether you've just been diagnosed or have experienced relapse, what is the best and most effective treatment we can provide? So whether it's the first relapse or subsequent relapses, we all hope to use better and safer drugs with fewer side effects, or drugs with lighter economic burdens, and then create the best possible efficacy and the longest survival for the first relapse. Of course, we hope to achieve deeper remission as much as possible, because at this time the overall condition of the patient is still relatively good. But if it's multiple relapses, what exactly are multiple relapses? For example, if I switch to a different treatment plan and it relapses, then if I switch to another treatment plan and it relapses again, so relapsing more than 3 times is what we basically call multiple relapses. Although at this point we talk about we aim to increase with the goal of not adding too much suffering and focusing on the quality of life. But it should be said, striving for maximum relief from this disease and ultimately improving our quality of life. It's just that we need more innovative drugs to deal with patients after multiple relapses so their disease. What treatment strategies should be adopted for multiple myeloma in order to achieve maximum relief? Talking about our main topic today, if we want to achieve such maximum relief, what should our treatment strategy be? So here just mentioned the concept of recurrence and primary resistance. What about primary resistance? What we see now is very rare. That is, in the first round of treatment, the efficacy does not reach above minimal relief. So for our group of patients now, actually, it's less than 10% or even less than 5%. Most patients can achieve good results in the first treatment. So what we see more of now is recurrence. After recurrence, the goal is to use different mechanisms or drugs that have not been used before. For example, the mainstream drugs now, bortezomib, carfilzomib, ixazomib, such drugs, we call them proteasome inhibitors. Then what about immunomodulators? Including lenalidomide, pomalidomide, and there are some newly developed drugs later. So bortezomib combined with lenalidomide is now commonly used as first-line treatment. What about after recurrence? We will switch to the next generation drugs or add drugs with different mechanisms, such as CD38 monoclonal antibodies and so on. If the first treatment, such as bortezomib, is effective, in between, we can transplant, then we use lenalidomide orally. Later when it recurs, we can also reuse the previously effective drugs. So the general principle is like this. For relapsed/refractory multiple myeloma, what are the grades of response? So we will use a series of standards to assess the efficacy after treatment. Last year, our Chinese guidelines have also been updated for its efficacy, so this patient or family member may be quite familiar with this concept. In general, complete remission means that this abnormal protein detected in blood and urine, this abnormal protein disappears. If it's strictly complete remission, it's favorable, convenient, and normal. Is there something a bit more stimulating? Possibly a tiny bit remaining. We call it very good partial remission, achieving over 50% remission. We call it partial remission. Then there's what we call MRD. What's the concept of MRD? MRD is the full name of minimal residual disease. Its Chinese name is minimal residual disease. If everyone can imagine an iceberg on the sea surface, the part we can see on the sea surface, it's like what we can detect in terms of the abnormal protein. If it's below the sea level, the fact that you can't see it doesn't mean it doesn't exist. Multiple myeloma is like this too. Even after bone marrow aspiration, if you can't see these abnormal cells with the naked eye, it doesn't mean they're not there. So, with this disease, it's a bit like the wildfire that can't be completely extinguished. It grows back after the spring breeze. But now, we'll use various methods to try our best to minimize its residual disease, so that each treatment, whether it's the first or subsequent ones, can minimize its residual disease. Currently, what we can detect in the bone marrow as minimal residual disease is what we do with flow cytometry or sequencing tests. We can detect one cell among a million cells. The deeper we go, the cleaner we clear it, the longer we delay its next recurrence. So, the first treatment, although today we're talking about relapse, our first treatment now, if followed by autologous transplantation of 4 to 5 years for the patient. Just think, after 4 to 5 years, this disease may be cured. So, at any time, we should strive to achieve this standard and the deepest treatment possible. In this way, we create more opportunities for future treatments. This was in the previous year, in a highly authoritative clinical oncology journal, an article was published, which suggested that the current treatment for myeloma, along with sustained remission of minimal residual disease, may indicate that some patients can achieve functional cure. In other words, if you can't detect the tumor's abnormality or tumor markers long-term, then patients can live like normal people. That might be close to what we define as the standard for cure.